Okay, good morning again. So these are my disclosures. And, well, why I present this video? Maybe somebody of yours remember the crash of one of the bridges in Italy. And actually, at that time, I was proposed to have unrestricted grant by Alcon for a SciPass. And one day before I presented the request to the ethical committee, actually they withdrew their stuff from the market. So I felt a little bit like this guy who stopped a few meters before going down from the bridge. Why I'm saying this? Actually, Carsten already showed that this is not a new space to be addressed. It's more than 100 years that everybody is trying to do something to use the suprachoroidal space. They're being using from hair of the horses to sutures to everything. It never worked. So why are we confident, or why do we think that this might be working? Well, I think that this kind of procedure, Carsten already mentioned, is a little bit tougher, let's say, than implanting a SciPass, but have some advantages. And the main advantages is the material of the device we are implanting. I want to walk you a little bit more through into it. So this is made of silicone, but actually what we are implanting is we are implanting mainly air. Silicone is only 30%. So as our body is mainly built of water, but we don't see the water, here most of the implant is air and is pores. So there are more than 180,000 pores in each device. Why is this important? Well, one of the issues is the fact, and Carsten mentioned it, that you can have fibrosis. So from experiments in a rabbit model, they show that the implant is colonized by cells in some of its part, the one which is close to the choroid, but actually it's not completely colonized. So some of the pores are still working, and at the same time we don't see a capsule around the implant. And this might be because having these cells into the implant, our body recognizes it as it was its own. So in a way, one of the main issues, which is the post-implant spikes, should be lowered by this implant. So it's the procedure is ab interno, so it's safe and predictable. The fact that we are addressing the suprachoroidal space gets rid of using mitomycin and taking care of the bleb. And of course, the hope was to obtain meaningful and sustained performance by reducing both the intraocular pressure and the medication burden. This is to implement what Carsten showed you, is the implanter. Actually, it comes with a protective cap. You take it away, and then you can see the sheet. And within the sheet, there is the MINIject implant. As you can see, there's also a safety lock. This safety lock must be switched on, I mean, allowing the device to deliver the implant once you are into the anterior chamber or just before doing it. This is again a small animation to show you how it works, the procedure. So as in general, when you do this kind of procedures, you use a gonio lens. The MINIject sheet is flexible, so that it can actually, when you implant this kind of device, I would like to stop a little bit this presentation. I don't know whether I can. Yeah, I can. So one of the issues is the fact that in order to avoid to have a big cleft, you have to actually push towards the sclera while inserting. so that the sheet actually follows the curvature of the sclera from the inside. Now, once you have implanted, Carsten already showed you that there is this green ring that should be staying at the sclera and at the base of the iris. This is in order to avoid the implant to rub onto the cornea from the inside, and so cause damage to endothelium. And what, of course, nobody can show it alive, but what we think is that this implant is colonized over time by cells and eventually other parts, but without having a capsule, so without having a scarring around. This is the way you can see the implant right after the surgery, and this is after a while of patients that have been implanting in India. So I'm supposed to talk to you about the meta-analyses that have been performed on 3 separate studies. I want to point out that the STAR 1, which was the first in human, used a different kind of device to implant. So it was mainly designed to see whether there were any problems in the surgery. Nevertheless, we decided to include these 25 patients to have a better understanding of what was going on. Most of the patients were mild to moderate, but they were not compensated on eye drops, and they were followed up to 24 years. Of course, there have been different kind of patients included, and honestly, I've been in India and in Colombia, and I felt differences when implanting this device. So there might be differences in addressing the suprachoroidal space when you have more or less pigmented patients. And the iSTAR 2 has been mainly in Europe. So the objective was to assess the safety and efficacy of MINIject, and we looked at the reduction in diurnal IOP, in hypotensive medication, and the success rate. The success rate was defined as an IOP between 5 millimeters and 21 millimeters with, more than 20% reduction in IOP from baseline. And of course, there are some concerns with the safety. So they looked at the safety, including the endothelial cell loss. So you can see that actually the results are pretty brilliant. I want to point out that this is not a washed out pressure. So this is the pressure you are measuring in the office with the dial of your tonometer. So the starting pressure was around 24, it went down to 14.4, which is minus 39, which is quite a good reduction. But of course, I think that the means tells you little. I really like this way of presenting the graphs, and I would suggest everybody of yours who are presenting a paper on a journal to present also the pre and post-operative data. So on the x-axis, you have the baseline pressure, and on the y-axis, the pressure at 2 years. So if we draw this line, we can immediately see that some of the patients didn't perform well, and I want to point them out first. So those guys, they have the same pressure, almost the same pressure, it is the same, and this wasn't successful. But in general, if we put our success rate, so between 5 and 21, most of the points are within that square. Not only, if we draw a line which shows a 20% decrease, again, most of the patients were down there. And again, I want to point out that some of these patients had a really high pressure to start with, like this guy here, 35, which was at the end around 14 millimeters, which is quite a nice result. Also, if we draw a line showing the 18 millimeters, so a little bit more restrictive criterion, a lot of patients were under this line. If we take into consideration the patients who were medication-free, actually they even did better, because almost all the patients were under the 20% reduction in IOP between pre and post-op. And actually this is again a good news, because I mean, patients that goes well in any sense. Not only they have a decrease in pressure, but they have a strong decrease in medication. What were the most common adverse events? Of course, there was inflammation into the anterior chamber. Some Carsten showed you very well that there is some bleeding, so you can see some blood into the anterior chamber or some heme going around. There were IOP elevation, especially in the first postoperative period. Some patients showed a reduction in visual acuity, and most of them were because of progression in cataract, and some of them had a worsening of the visual field defect. The advantage of this procedure, of course, is the fact that there is no blood management or needling. I know that a lot of you have been implanting Dixen, and some of you had to needle quite a lot. And actually, what's also interesting is the fact that very few patients had hypothony, both in the early postoperative period and in the long term. We are all worried about endothelial cell loss. So now, if we compare the results of these three studies with the ones who are available in the literature for Dixen, for the PreserFlow, and for trabeculectomy, even though these data are 2 years, they compare favorably with the other devices. And actually, only one patient had more than 30% endothelial cell loss from baseline. So this device is a superciliary device, a superciliary MIGS. As I said, I'm not particularly fond of the superciliary space, but the advantage is that it's soft and flexible, so eventually it can minimize fibrosis and can be implanted as a standalone procedure ab interno. So it doesn't preclude other potential ways of performing surgery. And I think that in general, although the number of patients is not so big, up to 2 years, these three studies showed a really meaningful performance with a favorable safety profile. Now, the device is under IDE investigation in the US and is commercially available in Europe. I think that's all. I thank you for your attention, and I leave to you.